Good morning and welcome to our session, our Drink and Drugs News session. We're absolutely delighted to be at this wonderful conference, second session for it. I'm very heartened to see some hellos in the chat already. Can I just say before I start, please do use the chat to send us questions, give your comments, let us know you're here. It's very nice to know you're here. So a little bit about us. I'm Claire Brown, I'm editor of Drink and Drugs News, DDN magazine. Free magazine, goes out in print in the UK to everybody who works with drugs, with drug treatment, using drugs. We're a free magazine at the centre of the sector and very proud to be so. I'm here, my colleague Ian is just to the side of me. He's going to be looking at all your chat messages. So we'll be here for this session. The session of the right dose, important issue for us. It's about the importance of getting the right medication at the right level and optimal dosing, which we'll explain in some depth. Before I introduce our two speakers, I'd just like to take a little bit of time to look at some quotes over the years. DDN magazine's been running for 17 years, and over this time we've examined this issue in so many different contexts, from people panicking about needing to get the right dose, about struggling with the therapeutic alliance with their service providers, and about service providers doing their very best to get it right. So sometimes there's a disconnect. Quite often there's really good practice that puts people in the right place. And what we're interested in is bringing all of these comments together and seeing how we make it better as possible for people. So just to take you through these quotes very quickly. Yeah.
Click on
There we go. Technology rules, doesn't it? This is us, DDN magazine. You can subscribe free on our website. But here we are, back in 2006, the late great Alan Joyce, who was a senior advocate of the Alliance. And back then he was saying one chronic problem is underprescribing, more correctly known as subtherapeutic dosing. Many GPs prescribe methadone at levels way below government guidelines, refusing to consider a realistic dose. So understandably, patients continue to top or relapse. Treatment is routinely assessed outcomes. So I think that encapsulates what we're talking about all these years later. It's come up time and time again. We've worked with some fantastic doctors, Dr. Judith Yates among them. Heroin-related deaths had more than doubled at that time in England and Wales between 2012 and 2015. And this was when really the government was starting to gear up about drug-related deaths, but the tragedies have still escalate. One of the very obvious measures was to include low thresholds and to make sure people were and weren't dropping out stuff. Professor Alex Stevens back in 2017, and this was at a conference which was themed around drug-related deaths. Two of the clearest practical steps to reducing drug-related deaths are to invest in high-quality opioid substance therapy at optimal dosage and optimal duration. There's a mystery to this at all. We held a big session at in which we came to the very swift conclusion that this fits nobody who prescribing is concerned. We had people talking very openly about the problems they were encountering at the time. Angela said, "I feel that I can never say what's going on with me or ask for something like an increased dose because it means they'll probably reduce me or put me back on daily dispensing, which is impossible as I need to live." There you go, very practical issues. John said that an abstinence agenda at the time, law to reduce his medication. My prescription keeps me alive and I've been on it for a good 12 years, but they keep saying I need to reduce, that it's the law. And no, it isn't, but I have to fight at each appointment. So some of the work that we've been bringing to the fore over the years is for people to know their rights on this, and to know about services like Release, who can actually represent if things go wrong. This was a quote from the beginning of lockdown, Andrew Horn from Wales, about changes to prescribing and to systems, which have actually brought a whole new strand of innovation to what we're doing. They actually examined the way that they prescribe. People also felt much more in control of their lives and how they dealt with dosage. Instead of having to go to a chemist and drink the methadone a day, organisation changing its options, really positive stuff. We just gave people options as to what they were more with. Science, it's about using all the opportunities to work with people. And then Dame Carol Black, talking to people who use services, had given her insight that wherever they went, they were not really treated as normal people in the health service. That came through extremely strongly, that they didn't feel at all like they had a voice. So the issue of stigma is something that we will touch on today. Is this a barrier to actually getting the right dose? And I'll end with Nick's quote, Nick writing in DDN, Nick, who calls himself a service user, when he writes, very passionate, strong about his views, quite rightly so. Drug treatment is not for drug users, rather is an attempt to protect society from drug users. It's clear that drug treatment is primarily about society. Any iterations of the needs of drug users are secondary and afterthought. And this is one of our roles as a magazine, to try to quash this notion that nobody has a voice, because by having these conversations, we hope to change that culture and make sure it's not a thing. So if I can now move on to our discussion, I'm going to introduce our wonderful speakers. And so we have Dr. Prun Bijral, if I can have them back on the screen. Here we have Prun, consultant psychiatrist, medical director at Change Go Live, which is a major health and social care charity in the UK. Done all kinds of things, supported a number of national and international programmes over the years. Consultations, has been involved in the development of clinical guidelines for Nigeria. He currently supports the Public Health England National Good Practice Programme for opioid substitution therapy, and has worked very personally with a lot of people that we know. He's going to be talking to Peter Yarwood, who will bring his own personal experience to this debate. He founded Red Rose Recovery, which was established as a charity in 2012, has become nationally recognised for opportunities affected by substance misuse, offending behaviour. There are a lot of experience in Peter's peer group. Peter's in long-term recovery himself, continually works to help people who need it in a non-judgmental way. We got to know Peter years ago when he came to our service involvement conference. Then he had his band of fantastic peers with him and had created a group that's gone on to do great things. So welcome to both of you.
Thank
Prun,
you.
may I start? Could you just explain to us what we actually like optimal dosing, please?
Yeah, sure thing, Claire. So just I don't want to assume that people know exactly what we are talking about, even though we might know in the sector that it's a significant issue. What we're basically talking about is the treatments that are provided for people who might end up with a problem with using opioids, often say like heroin. The treatments that are evidence-based and effective are often called opioid substitution therapy or opioid medication-assisted treatment. So drugs and medications like methadone and buprenorphine are often used. Now, when we talk about getting the right dose and optimal dosing, we're not talking about anything, in theory, more complicated than somebody's got a problem. there's a medication here to help them, in this case, say methadone or buprenorphine, and everyone's individual needs are individual and unique. So what the dose for that person might be that helps them, say, not use any further opioids or reduce the use of opioids like heroin, it's about getting the balance of getting that dose right for them. So while your previous quotes are right, Claire, that the evidence base does suggest that higher doses, for example, or within a certain range of doses, there are more, you're more likely to get an effective outcome, as in people are more likely to receive the benefit of the treatment. The reality is that it's got to be about the person and their experience and whether that treatment is right for them in terms of how they feel in themselves. And we can talk more about that. But in a nutshell, we're trying to help people stay comfortable, get some stability in their lives for them to go on and do what they want to do next. That's the main point and purpose of it, really.
Yeah. Peter, do you want to give us your perspective on that, both from your own personal perspective and perhaps how it's affecting people that you work with now?
Yeah. Good morning, everyone, and thank you for inviting me onto this session. I think I've had a brief discussion with Gordon around setting up this session, and we started off by asking that question: what is the right dose? And very quickly, we realise there's lots of issues around it, but maybe we got to the point after say about an hour of putting the world to rights of saying maybe the right question is, what's the right relationship? Because it strikes me that when people enter into a treatment service, they're often at a very low point. That's my experience, and they're going there for some help. And added to that issue, they've got the fear of my whole life might be dependent on the outcome of this situation, so they're already going into it pretty anxious. And if their whole experience is rooted in I don't get heard, or I have to fight my way through every situation, then it just strikes me as a really important starting point to build a relationship where it's about truth and honesty, and sometimes that might mean recognizing that somebody might start from that place, understanding and appreciating where they are, and opening up a space for them to get honest. But I think it's really difficult, isn't it? Because you've got lots of people who are at different stages of development. So some people might not know what's right for them, and that's got to be a process. It can't often be fixed in one visit, one short visit, Claire. So I think like a starting point is getting a good relationship right and building trust, and they can be them in itself can be quite time consuming. And I would imagine, I don't prescribe, our service doesn't prescribe, we're kind of at the other end. We create opportunity for people to have a different experience, to integrate into society. And often we find that people build up some thinking distortions that they hold on to really tightly, and it alongside the treatment and the prescribing, what's required is a really kind, supportive environment. And that's why we always bring a troop of people down to the DDN, because we want to expose them to a space where it's okay to talk about issues that affect them. And often these are like really emotive issues, aren't they? When you've struggled with addiction for 20 or 30 years and you've not found a way through it, and you've just seen people dying, people who you care about, often you can paint a picture in your mind that, maybe isn't factual, but to you it's true. And then it's really easy to start pointing the finger and getting angry. And I suppose what we do is recognize that's a fundamental stage in people's development. And what we don't want to do is block them and say, you know, because you've behaved in this way or because you don't believe this, you're not going to be part of it. And I suppose I think that's part of what we do. We create a space. We've toyed about the idea of calling it the space program, but we don't want people to think we're off in the stratosphere anyway. So I suppose, yeah, it's a really important issue, isn't it?
Yeah, yeah. I mean, we all know that the people that are in danger here are the people that are not in services already. So you've got people who are happy to connect with services, and these people that are not, that are just out there, and you've somehow got to get this bridge of trust and confidence. I mean, where is this starting point for those people if they're not walking to you and saying that they're ready? I mean, do you have much experience of people coming and really not being sure whether they're ready to engage yet? I mean, how can we really extend that bridge to people to make sure that they are held within that treatment and don't just walk off the first?
Yeah, I think it's a great question, and you know, it's another aspect of treatment, and that is accessibility, isn't it? And my experience is that when people come to say they're ready to look at starting on treatment, for example, or making some changes, everyone's reasons are different, and everyone's kind of preparation and thought beforehand is different. But from a service provider perspective, our job, I think, is to be ready to respond to that opportunity, because it may not come back again anytime soon. So if I'm in, say, a clinic setting and I'm seeing somebody come in, and then I might be seeing somebody else straight after that, that person may have thought about that appointment for a couple of years. And we've got to recognize how big that might be for somebody. And it's not just, okay, who's next in a busy sort of doctor's clinic, you know, service diary. It's really, really important. So there is something about accessibility. You're absolutely spot on, Claire. A lot of people are dying from the consequences of the issue that they're experiencing, and our job is to be there for them. But we know that we're only serving, okay, a significant number of people, but there's a lot of people who aren't accessing treatment, and that's got to be a question as to why. So there is a point about accessibility, but just coming back to the dose part, ultimately it comes down to the quality of the treatment. We talked about sort of relationship. I mean, Pete said it right. It's got to be about honest conversations and things like that. But honestly speaking, why should people feel like they can't have an honest conversation when they're coming to get access for their health? You know, the reality is that as a doctor, I'm not going to be able to do my job if I don't know what the real issue is. And if somebody doesn't feel that they're able to speak honestly about their issues, then we're both at cross purposes, and we're never going to actually get to that point. So what I will always say to people is, look, it's your treatment. I can give you advice. I can tell you what your options are, but it's not for me to say you need to be on it for this long, or that's ridiculous, actually. It's for the person. So what I've always found quite helpful is really working on the relationship to help people understand that it's they're in control of their own treatment, and it's for us to actually serve and make that treatment accessible, as practical, as useful for them as possible, for what they want it for. And I think that's part of the problem. It's not our treatment. It's not service providers or doctors' treatment. It's the person's treatment. And in a lot of healthcare, I think that's all automatically kind of understood. I don't know why it's not in ours, and it shouldn't be the case, I don't think.
Thank you, Prun. Can I just encourage people to put in the chat some insight where the sticking points are for them, or for colleagues, or for people that they work with? You know, what are the real issues about not being able to access treatment? Where are we getting stuck? Because we at DDN do often hear people banging their heads against the wall and saying, I can't get what I need. You know, for instance, seeing it encapsulated at the start of the pandemic, there was mass panic that they wouldn't be able to get their scripts. They'd have to trek along across town, wait in queues for hours around the pharmacy. You know, there are all sorts of issues that have actually triggered better, more responsive practice. So if we drill back to what Prun is talking about here, are there any issues that you personally have experienced or that you would like answers to or would like to discuss? Please put them in the chat, because we know there are frustrations and we need to try to work together to actually come up with better practice right across the sector. So if we can move on now to just windows of opportunity that might bring in some imaginative thought. We've talked before, Peter, about homeless people and a chance for less formal interventions. You know, can you give us a bit of your experience on how you can pull people in, not by stealth, but you know what I mean? The treatment isn't the primary reason why they walk through the door, but suddenly it's something that will be life-changing because they get the right dose. But you're reaching out to them, literally like outreach. Could you give us a little bit of insight to that?
Yeah, I could give you loads. It's picking and choosing because it's such a rich subject. But I suppose how we operate is, I touched on it before, we have different access touch points, call them touch points, because I think one of the reasons why some of the people I know personally who aren't in treatment, you know, some of the people that have kind of left behind, say in Manchester, I live in Lancashire now, but I've still got family members, I've still got friends who are entrenched in this lifestyle, and I think one of the reasons why they don't enter the treatment because they can't see how it works for them, whereas, you know, it's like they can drug dealers make it really easy for them to access their supply. Sometimes they might have a perception that it's easier to access drugs on the street than it is to access the services, because I can get someone to my door straight away, but I can't get, you know, the treatment centre there. I have to, you know, get up out of bed, and I'm just not used to that. I'm not in that place. So that's one issue. But I think when we've got people who are in services, who are, you know, quite clear about the direction of travel, and they for one reason or another start using on top. I mean, recently it's such a, I don't want to get like contentious here, but one of the things me and Prom talked about was the difference between abstinent and getting well, and that's got to be the conversation. You know, what do you want to do? Do you want to get well? Because we can help you do that. And it often, I come into contact with people who they want to get abstinent, and they think if they just stop using all substances, then that's it, job done. And often it doesn't work like that. So we got into a conversation, then we run around. This is such a well-researched area, and there's lots of really good evidence for OST. What we do is make sure when people slip through the gaps, i.e. there's supported accommodation for people who get on that journey, and often the policies say, you know, if you use while you're in this abstinent-based supported accommodation, it'll trigger a policy and you'll be made homeless. And recently one of our guys tested positive for fentanyl, and for us that just set off so many red flags. You know, as an aging member of the recovery community who slipped into using drugs again, found himself homeless, and the system was really complex for him to navigate. We know there's a window of opportunity that opens when somebody's, you know, slipping back into harm's way and making decisions that taking them in a different direction to where they want to go, and they often get really confused about that. I suppose what we've got, maybe not as much as we used to have, is a smaller army of people, but the more skilled people, to identify what those signs are and what they're dealing with. And I suppose in this situation, after a couple of days of living on the street and going back and using, he realized, actually, I'm going to die if I don't turn this around quickly. And I suppose there wasn't capacity within the system to flex to that window of opportunity, but there was in the community, because there's lots of little groups of people who are all now banding together and saying, well, we can play a part as well alongside. And that's why I like, you know, the system we've got in Lancashire. There's a really good partnership that understands the different dynamics. So what we was able to do, working with a local church, is acquire enough money to put this lad in a hotel. And, you know, sake of a couple of £100, it meant he was secured accommodation for the 4 days from Friday to Tuesday. In that window of opportunity, the recovery community rallied round him, made sure he was fed, made sure that he had you know, he had a mobile phone that was charged up, he had somebody to speak to, you know, and that's the beautiful thing about having a vibrant community of people. Dead happy to say he's back into abstinent-based accommodation and working a program, and he's, you know, he comes to us now, you know, he makes his way to us of an evening and of a weekend, and I think that's got to be a part of the solution somewhere. But
yeah, those layers
we
that
also,
come, yeah.
we also have, Claire, sorry, we also have, we don't put people in boxes. We just recognise that people are people and they're beautiful, you know. And me and Prun talked about, we're all earthlings, aren't we? We all live on the same planet. You know, sometimes we create structures and barriers that make it difficult for people to engage, and it's not what we want to do. We want to make it really easy for people to engage.
Yeah. Well, I mean, you're lucky that you have such a good relationship between you and all of these people that you can create the structure from. But I know it's a lot of hard work and a lot of contact with a lot of people to do that. We've had a question in the chat from Fleur saying she's seen a lot of barriers around fears of judgment, mistreatment, a lack of trauma-informed approaches. And while she recognises that, you know, it is their treatment, she feels there's still a power issue, and many service users feel this. So we're back to this feeling of disconnect. You know, how? I mean, it's a huge question, and I know that being trauma-informed is a useful part of that. But how can we get past this, us and them? Have you got a thought on that?
May I come in? It's a really important question, and that's the reality of it too. There is a dynamic there. It would be wrong to not acknowledge that there absolutely is. It's how you work with that, and I think as a doctor, I've always I've understood it as best as I can. You know, and you keep on trying to understand it, but you've got to remember it. And one of the things I've kind of thought about is that it might be quite a scary thing potentially for somebody to be coming in and having to talk about their health generally. At the best of times, you know, if you've got something wrong with you, you go to the GP or something. It's maybe not unreasonable to feel a bit anxious because you don't know exactly what's going to happen or otherwise. So you're immediately in a potentially vulnerable place as a person. And so if you're in that clinic setting or that treatment setting and your interaction with this person could be make or break for their actual health and life potentially, you've got to recognize that. And it doesn't hurt to really make some assumptions that it might be really tough. So do your best to make that person feel comfortable, make them feel that you actually are there for them rather than I've got some kind of agenda, I'm going to try and get you on this or that or otherwise, that you really, really listen to them and be there for them and not to push any ideas, but to be there to help inform people. So I think that's part of the issue about shifting that power issue to actually really help people understand and be comfortable with the idea that this is their treatment. I'm here to serve you. I'm here to help you meet your needs as best as possible with treatment or prescribed treatment. And that's my job. That's my purpose, really. And it does go back to that relationship. And you know, obviously, if you know somebody a little bit and you develop that relationship, it's easier to have an honest conversation, and it's easier to be open. And what that means is when you are open, you are effectively dropping down your guard and dropping down your defenses. Hence, you're potentially going to feel more vulnerable. People need to feel able to do that without feeling judged. There were some comments before. I think you were saying, Claire, that in some of the comments, you know, coming in feeling like whatever I say might have an impact on my dose. Might that mean I'm, you know, my dose is changed or otherwise? That's scary. I think that might be scary. If I was on a treatment which I knew had saved my life, and I knew was a big part of the foundation of my stability, and on the face of it, it looks like I'm fine and well and doing great, but underneath, it's because of a lot of hard work on a daily basis to keep that in mind and to keep in touch with, you know, all the things that are keeping me well, and medication might be a big part of that. I don't want anyone touching or interfering in that, because nobody will really know better than me as a person who needs that, what that means. And I think that's a big part of it, that if people go there with that relationship with their treatment, thinking that that could just be changed on the back of one bit of information that I've said wrong, that maybe I did use the other day, or yeah, I'm not doing so well, or I might need a better dose for me. It's really sad that could lead to I'm not sure, maybe we go the other way. You know, to be really frank, the whole purpose of medication assisted treatment, OST, is to help people not use. So it's it's obviously contradictory that if somebody comes in and says, for example, yeah, it's not working out for me, I've ended up using or whatever, the conversation moving towards, well, that might put your treatment at risk or your current stability and dose at risk, versus how do we make it better for you? Is that something that you need? Is it not even the medication? Is it other things going on in your life that we might be able to help you for? Do you need space to talk about it? You know, it's that is the reality, probably for a lot of people's experience, which has to change.
Yeah, I mean, that's absolutely spot on. And when you're talking about an individual and two people talking together, it makes perfect sense to approach it in that way. Peter Furlong in the chat has sort of built on that point, saying often the power dynamic isn't recognised or discussed enough within services. And the reason why people don't feel they can be honest around their script or treatment. On that point, I know this is probably an impossible question, but how can we try to bring about culture change within an organisation? And, you know, your organisation, Prun, has a lot of influence. You know, how do we make more of you in these therapeutic relationships? You know, you're doing the best you can and achieving great results in partnership with Peter and his guys. You know, how can we make sure that this goes further and isn't just one great piece of practice that stays right there?
Shall I start there, Claire? I mean, I think
it's a bit of a challenge of a question, isn't it? No, look what you said right at the beginning. The evidence for this treatment is long-standing. There's decades of evidence. It's one of the most effectively researched areas of medicine. So there's no question about the effectiveness of the thing, you know, the treatment that we're talking about. But the reality is, and I think have to acknowledge as well, we do talk about relationships. I don't think anybody, Pete, you said this to me before, nobody is going into here wanting people to fail. You know, people that, so colleagues in our organization sector, in the, you know, Pete in your organization, and just people who want to help, want to help people, essentially. But when we looked at the issue of suboptimal treatment, it's actually a long-standing issue. It's been there for a very, very long time. And we started looking, how do we address it in the organization?
And it really came down to a couple of actually quite simple things. And we've made good progress. I mean, we're not there yet. We never will be. We'll always want to be doing better. But it came down to education. I know it sounds really boring about training and education. It's not the answer to everything, but it was a start. It's about the education is demystifying treatment and actually just putting it in there as in it's not the be all and end all, but it's an essential part, maybe the first part of a foundation of stability. You've got to get that right. But it's not rocket science. It's get the dose that helps that person feel comfortable. And from a frontline perspective, that could be, am I craving? Do I feel can I wake up in the morning, have a cup of coffee and have something to eat before I say go to the pharmacist? Or am I up early thinking I need to get there? And if I miss my dose, that's going to be really difficult. That's not a nice experience for somebody. So it's just making those things right. And what we did was we made the guidance and the information more accessible to our frontline staff. We changed our training for people to help them understand how do you get an optimal doses. What are some of the barriers that have been mentioned by today already? And then the crucial was actually showing them the information about their own practice. Now this is for a service. This was the game changer actually. People know about optimal dosing or not, but until they actually know what the quality of the treatment is that's being prescribed, it's just opinion. And then it's like, well, I think we're doing all right, or I think we're not doing all right. The key thing was to actually show services and leaders within the services and then the front line that actually this is how you're prescribing. This is what treatment looks like for you. And what we did find when we looked at our own practice is that, yeah, those same issues persisted. There was a lot of people underdosed. There was a lot of people still using, showing that they were using and probably didn't want to use, however, still on underdose. And it's basically like, well, we're not providing the treatment for the need. It was as simple as that. And when we started showing that information to people, they automatically started to change, to have different conversations. And I'll never forget a really lovely story. Colleagues in the Northwest. So I'm based in Manchester, and colleagues in a neighbouring service were working with other partners in the community, and one of them happened to be a criminal justice service that they were working with, and some of the police. And they started educating the police who they were in contact with about optimal dosing, because it was a conversation we were having. And one of the coppers came back and said, so-and-so who we both know and have known for a long time, I mentioned about treatment, I mentioned about dose, and he started having a conversation with them about it and encouraged them to come in and actually get to have a conversation with the treatment provider for an increased dose. And it did make a change. And we've had people that have never been abstinent, if you like, or never provided, say, a sample, a urine sample or a test which hasn't had something in it. And just like small change actually made a difference. And that was really interesting. So what we've done is really just demystify it, show people the evidence, show them their practice, and believing in them that they will actually do the right thing and try and improve the quality of what people are getting. And so far, so good, but it's a slow journey for sure. It needs to improve.
So that demystifying and that relationship is really important. I mean, the other thing that's coming through very strongly on the chat are the hurdles, the barriers, the feeling of stigma. Samantha says if she goes to her prescriber for a health issue, she wants to be treated for that issue and not have treatment for her drug use constantly questioned. And Lee also mentions too many hurdles. There's a frustration that makes people shut off from actually getting the best out of this therapeutic relationship. What can we do to address stigma? I mean, Peter, this must be something that comes up time and again in lots of different texts with the people that you work with.
Yeah.
How do you just encourage the most forward and that this, I'm not being treated right, this isn't for me, so I'm just going to retreat and just, whatever happens to me happens. How do we address stigma?
I think the solution is broader than just a clinical one. I think it's a social one. there's work that needs to be done in the community to educate the community and bring them up to speed with the issues that surround it, and then to highlight the support, there's a solution. You're not in this on your own. Some of the issues, some of the barriers are around shame and guilt, and they're born from the stigma. So, you know, I think it's every conversations you could be having a conversation with somebody and present your view of the world to them, and that could have a dramatic effect on whether or not they reach out to you at a later date. And I've often had conversations with people and really had to challenge the thinking about some of these issues, but how we address it. We get out in the community and we look for opportunities to serve, to give back, to try and get out of ourselves and into helping somebody else. And often, you know, we operate in what's called the VCFS, the voluntary community, and the faith sector. And there's a huge faith sector out there of people who part of operating, I suppose, part of practicing their faith means they want to help people, and we've said, you know, we want to do that as well. We want to help people. We get a good feeling out of it, but because we're perceived or because we're painted a certain way, we sometimes get blocked from doing that, and that's a fundamental part of my life. My well-being is connected to that. So if we're being painted a particular way, let's have a look at how we can change that picture by attaching some hands and feet to some good, you know, some good news stories and promote them and publish them. The good thing is we no longer have to go through you know, news outlets to do that. We've got access to platforms. We can put our stories out. We can no longer suffer the consequences of how people think because they've been influenced by the negative voices, the loudest voices. We can counterbalance that with actually we've just managed we've talked about this a few times. We've got a few minutes. We have an annual camp. There's a few things we do annually. One of them is come to the DDN, but one of them is a camp, and we mobilise people from all over the Northwest to come together in a field, and we just say, these are our values, stick to them, and we'll all have some great fun. One year, a family came into the field because they just seen so much fun and laughter and set up the camp, and it was like, great. It's not just for the recovery community or people who've experienced the issues around it, it's for everyone. And this family, they had a small child with them called, I won't mention his name, but anytime anybody met this child, it was really apparent that he had issues. He was Down syndrome, and that was often the first thing people noticed about him. It wasn't the fact that he was a little boy and he had a beautiful smile and he was so loving and kind. It was he's got some challenges, and we really started to reflect on that and thought often that's the first point of contact we have with society when we say, yeah, we've got a history. We might have been to prison, or you know, we might have struggled in life with some issues, but we can change it. So we said to this family, you know, we want to kind of drop some love into your world, and it transpired that they come from a local housing estate, low socio-economic background, and they didn't have access to much resources. You know, the breadline was something they were aiming to reach for. So when we found out that her back garden was full of rubbish, and this is just one example, there's many, we said, we'll manage a team of people, because our community has skills and abilities, but often they're overlooked. So we put the shout out. We found, first of all, we found that the broader system was willing to help. So local builders said they'll supply decking. The local social landlords said they were happy to rubber stamp and risk assess. We just supplied skill set and the people to go in and build this family a safe sensory space for the kids to play in. And we got some before and after pictures. What we did with that is say, look, you know, we're here, you know, we're not going anywhere, and we can be a massive asset. We're not just a drain, you know, a group of people to be marginalized and stigmatized. We're actually people who can contribute, but some of the systems prevent us from doing it because we don't fit in traditional boxes. So that's some of the things we do, and we've done it with local churches who've got aging congregations. You know, we've just sent teams in there, and we've said we're not going to hide the fact that we've got issues and we're working through them. In fact, we're going to use it to say, if you've got those issues, but you're putting a smother on it, you know, and it's a bit undercover, then when you're ready, you know who we are, where we are, and how to contact us and connect in with us. And often at the beginning of these projects, we know what people, we're not daft, we know what time it is. We see them following us round, locking doors when we're there, watching the handbags at the beginning of the, you know, interaction. But at the end of the week, that's when they realize, actually, we might have been getting it wrong. And we realize the voices that have influenced our choices might not be the right ones we're listening to, because our experience, experience of connecting with these people is the good, and they just want to help like we do. They're the same. We're all like, we all live on the same planet. And what that does is that opens up resources. It helps us. We have this saying, you know, your resources lie within your relationships. But I think one of the issues we recognize is our people are in such turmoil, they struggle to sustain relationships. So they end up very isolated and alone. And these are like some of the core issues that need addressing alongside the treatment. And that's why you're right, Claire. We're really fortunate in Lancashire that we've got a treatment system that recognises the other elements and is willing to invest resources, you know, be that training, be that venues, be that, you know, just, I mean, some of the people who give me time to coach and mentor me, and, you know, it's not always, it doesn't always have to be money. It don't.
No, what you're saying makes absolute sense, and there's testament to that in the chat. Rebecca says, amazing to hear Peter talking so passionately. I've had major support from me and my partner from Red Rose Recovery and Love. I could not have done the past few months without them. So that's where it's really hitting home what a difference you're making. I just want to move on to a question by Vincent about a postcode lottery, because this comes up again and again. If I can find the question. In my experience, varied from area to area. Cheshire, dosage was 120 millilitres, and in Wirral, it was 60 to 80 millilitres. This became contentious, especially when service user transferred across services. Prun, can I ask you, well, it's not solvable, but, you know, what do we do for people that are experiencing this awful fluctuation?
It's a simple answer and not a simple solution necessarily, but this is our responsibility. It's about the person and where they're at and what matters to them, not where they've come from or where they go. And if a provider or an area has a certain way of doing things, bottom line is that way of doing things has to be in line with the guidance, the recommended, you know, the evidence base that's there to help them is key. And not just, I fancy providing this dose because that's just how I woke up this morning. And it's not good enough, effectively. the reality is, I think, Claire, is that, you know, all our services, we don't have fancy machines or anything like that. They're all about people, aren't they? You know, we're people services. So you're going to get differences, and you're going to the double edge of being unique and different and individual, and that is sometimes that comes with beliefs and other things that are unique to that person, and bias. But really, to Vince's question, it does come down to the quality. It comes down to awareness. It comes down to shining a light on the actual treatment that's being provided. So if as a provider, you know, a commissioner will come and say, look, we need a drug treatment service for our community, and can you please provide a treatment according to the evidence base in the guidelines? They'll say that. Whether that's being done or not is the responsibility of providers and the commissioners to actually know that and judge that. So for me, I think it's about quality. We've got to move more towards a focus on the quality and what people deserve rather than the minimum of what they deserve. But a better quality, a better, as a doctor, treatment experience is much more than treatment, much more than just the clinical element. It's a key part. But we've got to get to that point. It's about improving the experience all the time. If it was say my family, my loved one that was going to access treatment, that's all I would want for them. I would want the best experience for them getting what they need, feeling heard, wanting to go back, feeling safe in that place. What's the difference for anybody? It's somebody's loved one, right? It's somebody's life. It's somebody's world. It's as important as anything. And we've got to view it from people's perspective, not a provider perspective, a commissioner perspective. It's got to be about the person, I think. Yeah.
And I think the point to add to that, Rebecca Charlson makes a point about the lack of joined up services. She's a family support worker supporting a family where 3 people need help and support. The 3 people, the mother, the son and the daughter, each have different services, 3 different support workers supporting one family. Yeah. So you can't have a meeting as a family to enable everybody to work together. And she finds that bewildering. So that's another element. I'm not sure if either of you want to comment on that, but that's certainly something that needs to be brought in. Perhaps, Peter, do you have any links with family support, anything that you can suggest on that in joined up care?
Yeah, I mean, our approach is always to empower, and we're not trying to control. It's got to come from an individual. So what we look for is people who want to help other people who are going through similar issues, call that mutual aid. And we have a service, you know, that's run and managed by us, and there's a contract. It enables us to create employment and be a part of the system. But we then have, like, what I would consider to be the gold standard, the network where they're doing it for themselves, and we kind of step back and are just there when they need some training or when they come up against issues they can't navigate. But fundamentally, they're building support for themselves. They're doing it for themselves. And I think that's a very one-dimensional approach, isn't it? And the Carol Black review highlights, you know, there's a need for a better, more coordinated approach, because it's no longer, I think, acceptable to say we're not going to work with other parts of the system. But yeah, I see it. It's still happens on our patch. We work this way, and we, you know, we don't want to work with anyone else. We and that's like sometimes part of the problem, isn't it? Because people don't practice what's evidence-based. They practice what is personally their opinion is what's right, and sometimes that's a bit of a difficult
I mean, you mentioned the Dame Carol Black report, and perhaps that's the positive note to end on. She mentions the importance of him. Do you both believe that this is a chance to actually have some unification and a voice? It's something that we've been trying to gain in DDN and write about it, this is an opportunity for the sector to actually showcase all of the good things that are going, all of the things that do work, all the things you've touched upon this morning. Can we actually put those succinctly as our response from the sector that this needs to happen, it has to happen, it has to be informed by people who know because they've been there? Either of you?
Absolutely. Pete, shall I start? That's absolutely right. That's the only reason we exist, actually. And I managed to access the chat, and I was kind of looking through it, and somebody made a comment, I think it was Lee, saying it's about, it's not what the providers, it might not be Lee, so apologies if I've got the name wrong, but it's not about what the providers want, it's about what the people want. And actually, we if I think, in our organization, for example, we have many thousands of people we work with, volunteers, we work with peers, we work with, our colleagues, clinicians, nurses, a whole range of people. But our biggest stakeholder is probably, when I think about the work that I need to do and how we need to improve, our community of, people with lived experience. So within the organization who access the wider community, and that is the voice that it's not about hearing that voice, that it's about enabling people to take control of things like commissioning, to take control of what policy, what is right. Which you mentioned before, Claire, about in the pandemic, how things had to change. They did have to change, but some good came out of that. And the feedback we had was that people really actually found it, in some aspects of it, if there is a silver lining, some things about making treatment better. And that was an incredibly strong voice that came through. We can't just kind of go, oh yeah, we hear you now. Actually, that's the way our services need to be shaped. If you ask the people most affected by change and by the system, and listen and actually change it for them, who are the peers, then you're going to have a better system and you're going to have a better service. It's got to be more than just me saying that. I mean, doing it is not easy. It isn't. If any of these things were easy, they'd have happened by now. But it is complex without question. But you've got to start at the principles, and that is. I'll just go back to what Pete said. It's about people. It's not about people who use drugs or people who've got a problem with drugs. It's about people and respecting people and being there for them. You could be there tomorrow. We've got to be kind and be helpful for people. And from my perspective, if it's hard enough to navigate these systems we're talking about, and actually the disconnect, and the reality is that the stigma is most often felt in a healthcare setting, actually, and and these touch points with statutory services, the very last thing that needs to be felt like is within the services that are specifically commissioned to support people who are using drugs. So yeah, we just got, those are important principles to keep in mind for us.
Yeah, thank you. Absolutely fantastic this morning. Well, Peter, if you want to say a few closing words as well, but I just want to thank you both ever so much. While you say a few words, Peter, I'll just hold up my email address on my box so that if anybody has comments, thoughts, I think Ian's put it in the chat. Okay, brilliant. Please get in touch with us if you've got any thoughts, because we'll be writing this up after the session. Fantastic, thank you. Peter, would you like to close off? And thank you both ever so much. And thank you for everybody who's made comments in the chat and been with us this morning. And we hope to take this further. Thank you. Peter, would you like to just say a word?
Thank you. I think the last word for me would probably be where we started. It's about getting the relationship right and walking into that relationship, understanding that nobody's setting out to, actually, let's talk about what they are setting out to, not what they're not setting out to do. Everybody wants to help somebody get their, improve their well-being, get to their destination. Nobody's trying to stop people doing that. So that's not to say we might not get it wrong. And if we do, then we need to be mature enough to open up a space to explore where we're getting it wrong without taking it as a personal criticism. And I know that's sometimes difficult, but if that's still not happening, then we would happily, you know, open up a conversation to advocate and on behalf of people if they're not getting that experience, if they're struggling to find a way through. Go on our website, touch base with one of us on one of the social media streams, and we'll see what we can do to help and advocate.
Brilliant. Thank you both so much.
Thank you.
Thank you.
Thanks.